Dr. Hoyt, you're recognized for 5 minutes.
Chairman Pitts, Ranking Member Pallone, members of the subcommittee, I'm David Hoyt, trauma surgeon and the Executive Director of the American College of Surgeons. On behalf of the more than 75,000 members of the college, I want to thank you for inviting the American College of Surgeons to testify today. The college recognizes that developing a long-term solution to the failing sustainable growth rate formula for Medicare payment is an enormous undertaking, particularly in light of the need to limit the growth in healthcare spending. The college understands that the current fee-for-service model is unsustainable and maintains that any new payment should be part of an evolutionary process that achieves the ultimate goals of increasing the quality of patient care, reducing the growth of healthcare spending. We assert that these two are directly related objectives. The first step toward reforming Medicare payment formula is to immediately eliminate the SGR and set a realistic budget baseline for future Medicare payment updates. The new baseline should fairly reflect the costs of providing quality health care, preserve the patient-physician relationship, and ensure that patients have continued access to the physician of their choice. Following the elimination of the SGR, we believe it is essential to provide a transition period of up to 5 years to allow for testing, development, and future implementation of a wide range of alternative payment models aimed at improving quality and increasing the integration of care. To that end, the college is currently analyzing the role of creating bundled payments around surgical episodes of care. The primary goal of a bundled payment model is to improve the quality and coordination of patient care through the alignment of financial incentives for surgeons and hospitals. One approach to bundled payments combines payments to surgeons and hospitals for an episode of inpatient surgery into a single fee. The ideal surgical procedures to bundle include elective, high-volume, and/or high-expenditure operations that can be risk-adjusted and for which relevant evidence-based or appropriateness criteria exist. In order for a bundled payment to be successful, certain safeguards must be included, such as ensuring quality of patient care and physician-led decision-making about how and to whom the bundled payments are distributed. With the right approaches, we can improve both quality of patient care and at the same time reduce health care costs. The American College of Surgeons has been able to significantly improve surgical quality for more than 100 years in the specific fields of trauma, bariatric surgery, cancer, and surgery as a whole. These initiatives reduce complications and save lives, which translates into lower costs, better outcomes, and greater access. Based on the results of our own quality programs, such as the National Surgical Quality Improvement Program, or ACS-NSQIP, we have learned that 4 key principles are required to measurably improve the quality of care and increase value. They are setting the appropriate standards, building the right infrastructure, using the right data to measure performance, and verifying the processes with external peer review. The first, the core process that must be followed in any quality improvement program is to establish, follow, and continually reassess and improve best practice. Standards must be set based on scientific evidence so that surgeons and other healthcare providers can choose the right care at the right time given the patient's condition. It could be as fundamental as ensuring that surgeons and nurses wash their hands before an operation, as urgent as assessing and triaging a critically injured patient in the field, or as complex as guiding a cancer patient through treatment and rehabilitation. Secondly, to provide the highest level quality care, surgical facilities must have in place appropriate and inadequate infrastructure, such as staffing, specialists, and equipment. For example, in emergency care, we know that hospitals have to have proper staff, equipment such as CT scanners, and infection prevention measures. If the appropriate structures are not in place, patients' risk increases. Third, we all want to improve the quality of care we provide for our patients, but hospitals cannot improve quality if they cannot measure quality. They cannot measure quality without valid, robust data which allow them to compare their results to others with similar hospitals or amongst similar patients. It is critical that quality programs collect risk-adjusted information about patients before, during, and after their hospital visit. Patient clinical charts, not insurance or Medicare claims, are the best sources of this type of data. And then finally, the final principle is to verify quality. Hospitals and providers must allow an external authority to periodically verify that the right processes and facilities are in place, that outcomes are being measured and benchmarked, and that the hospitals and providers are doing something to address the problems they identify. The best quality programs have long required that processes, structures, and outcomes of care be verified by an outside body. Emphasis on external audits will accompany efforts to tie payment to performance and rank the quality of care provided. The Patient Protection and Affordable Care Act is intensifying the focus on quality. We believe that complications and costs can be reduced and care and outcomes improved on a continuous basis using these principles that I've outlined and should be the basis for payment reform. The college welcomes the heightened focus on quality. The evidence is strong. We can improve quality, prevent complications, and reduce costs. Most of all, this is good news for patients. Again, thank you, Mr. Chairman, for the opportunity to share our college comments.
The chair thanks you, Dr. Hoyt, for your recommendations, testimonies. The committee will stand in recess until 10 minutes after the second vote.